Yes, I'm Jennifer Diaz, nurse practitioner in the craniofacial clinic at Boys Town National Research Hospital. So thank you for having me here today so I can educate you on the world of living with a cleft lip and palate. But just to give you some insight as to my role within our clinic, because we work with so many different providers in this craniofacial team, I am the team lead who kind of is that liaison between all the different providers and helping manage a patient's care. I primarily work with our plastic surgeon, Dr. Jason Miller, and then Dr. Lyndon Fornoff, who is our pediatric neurosurgeon. So I split my time between both of them half the week. So half of the week is clinic, half the week is surgery. So I have a nice balance. I've been in this role for about, almost 6 years, and I absolutely love it. I love building relationships with these families and watching these children grow. It's pretty amazing. So I will begin with living with the craniofacial anomaly. So our learning objectives today. First off, we'll identify what is a cleft lip and palate. There are so many variations when it comes to clefting, and we'll also talk about how the clefting occurs. We'll also talk about the incidence and prevalence related to cleft lip and palate. I will explain the roles within the craniofacial team, because that plays a big part with their care in the future. Just a few common genetic syndromes associated with cleft lip and palate. I'll also talk about pre-surgical interventions that we can do, and then the sequence of surgeries that these children actually go through. Oftentimes, parents will come and see us for the very first time, and they think, oh, the lip is done, the palate's done, we're out of here. That's not the case. So there's a long series of events that they have to go through throughout their childhood. And then I'll talk about some post-op cares, and that way you guys can get an idea of what to expect after surgery. So cleft lip and palate. What is this? So by definition, a cleft is an abnormal space in either the upper lip, the alveolus, which is your gum ridge, okay, and or palate. So in utero, there are tissues that form from each side of the head that grow together towards the center to create your face. So when the tissues fail to join by the 5th week of life, that then creates the cleft lip. And then similarly, when it fails to join in the roof of the mouth by 8 to 9 weeks of life, that creates that cleft palate. So like I said, there are a variety of different clefts here. So you can see I found a good image kind of showing that. So we first identify clefts if they are what's called a complete cleft lip or palate or incomplete. So complete means it extends from the lip to the nose to the alveolar ridge into the hard and soft palate. We then have what's incomplete cleft, which is when it just involves the lip and that nasal sill is still intact. We then identify if it's a unilateral cleft or a bilateral cleft. There's also what's called a microform cleft lip. This is a form of an incomplete cleft lip where there's an incomplete separation of the lip with a little bit of distortion, but it doesn't involve any separation along that vermilion border, which is that lining here that joins your lip and the upper lip of your skin. We then identify whether they have a cleft palate, and this can either be a hard and or soft palate. And then sometimes there's what's called a submucous cleft palate, and also known as like an occult cleft palate. This is where, if you were to look intraorally, that oral mucosa appears intact. However, that musculature within that soft palate, there is clefting along that musculature. A lot of patients will come see us in clinic, get referred when they have what's called a bifid uvula or split uvula. In those instances, we have to rule out whether these patients have a submucous cleft palate or not. A good indicator when assessing intraorally, you might notice a bluish tint or translucency to the soft palate, or sometimes there can be a notch along that hard palate as well. So the incidence and the prevalence. So this is cleft lip and palate is the most common congenital birth defect. It happens in about 1 in 6,800 babies worldwide. About 1 in 1,600 are born with a cleft lip and palate alone in the US. About 1 in 2,800 babies are born with a cleft lip alone in the US. And then 1 in 2,000 babies are born with just a cleft palate in the US. With regards to gender, you see this more so in males versus females, and I should specify with a cleft lip and palate. And then for those that just have a cleft palate, you might notice this happens more so in females versus males. With regards to laterality, we see more unilateral clefts versus bilateral clefts. So we see a good 4-to-1 ratio when it comes to that. And then surprisingly enough, left-sided cleft lips are more popular than right-sided cleft lips. So that accounts about 70% of cases that we see. With regards to ethnicity, you see this more so in the Asian population, followed by Caucasians, and then African Americans. So risk factors and diagnosis. So the cause is often unknown. So it's led to believe, according to the CDC, there are other contributing factors that can lead to cleft lip and palate. So we have a genetic component, smoking, diabetes, and then teratogenic medications such as topiramate, valproic acid, phenytoin, retinoic acid, and thalidomide. Now for diagnosis. So this is often discovered during the prenatal ultrasounds that these mothers go through when they do the anatomy scans, usually roughly around that 18 to 24 week mark. Now, ultrasounds are good screening tools, okay, to identify if a cleft lip does exist. However, it doesn't determine whether or not a cleft palate truly exists or not. A lot of the times it's more often because of positioning of the baby and so forth. So one good way to determine if a cleft palate is there is discovered at birth. So you just have to do a thorough physical examination. Sometimes these babies will go through eating issues. So one differential could be possibly a submucous cleft palate or not. So once again, we have to make sure that these providers are doing thorough examinations. So our craniofacial team. So we've been in business. I had to reach out to one of our retired craniofacial nurses. We've been in business since the early 1980s. So we've had this team at Boys Town for quite some time. So we work as a multi-interdisciplinary team. I'll be going over all the different providers that these patients see, but it's really nice for these families. The best way to optimize their outcomes, honestly, is to have all the providers in a clinic setting, seeing all the patients at different times. It saves them different trips to clinic visits. So I will say these clinic visits take a long time. Our clinic can range from 8 to noon, but at least they're knocking out all these providers in one clinic visit. So we follow a child from birth to adulthood. Like I said earlier, before, it's not a one and done. We have a series of things that we need to address. We have to have these weekly meetings that we do during our lunch period. So our photographer takes photos of all our patients, and then I have to go through every single patient and go through each provider and ask them their recommendations. And then I end up formulating a plan thereafter. We are the only ACPA approved team. So we're the only accredited team by this organization. So we are very, very proud of that. So the roles of team members and why. So we'll just kind of dive deeper into our team members and why they play such an important role in a child living with a cleft lip and palate. So generally all the patients that, they don't see all the providers that I'm going to mention, but it just really, like I said, depends on their journey, at what point in time in their life, any medical or surgical decision making that they may have. So the first discipline we have here is audiology. So they focus on hearing and middle ear function. They assess and manage hearing deficits because these patients are at high risk for middle ear disease and hearing loss. So based on the anatomy, having that open space intraorally, these patients tend to develop fluid in their ears. Their eustachian tube doesn't drain properly, so they're at risk for that chronic hearing loss. The audiology department will also help manage hearing aids and BAHA devices, which stand for bone anchored hearing devices. So they'll help aid with that. And then next we have our otolaryngologist, which is also known as your ear, nose, and throat doctor. But our ENT department works hand in hand with audiology because they will get diagnostic information from audiology, which are called tympanograms or audiograms. And that information is helpful because they'll kind of help determine if surgery is indicated or not. And that could be examples like ear tubes, adenoidectomies, tonsillectomies, and so much more. But ENT is responsible for the hearing, middle ear function, and treatment of middle ear disease. And then also to assess that oral nasal cavity as well. We next have our geneticist who plays a very important role because they really provide care in terms of necessary planning for their future and management for the future. So they perform very comprehensive evaluations, which can include a family pedigree. They can also do very, very detailed physical exams, which plays a huge part in their role. They help identify if clefts are syndromic or non-syndromic. They also plan for any necessary diagnostic testing and referrals. And some testing examples would include, they might recommend some echoes, renal ultrasounds, spinal x-rays, and then genetic testing such as chromosomal microarrays and whole exome sequencing. They help counsel for future pregnancies and recurrence risks. So sometimes they'll often recommend folic acid, increase in folic acid a few months prior to conception for future pregnancies. So next we have our orthodontist, who's a part of our team, and he's responsible for educating on the oral hygiene. So if you do not have proper oral hygiene, you are not a good candidate for orthodontic treatment. So we really stress the importance with that. We'll pass out toothbrushes here and there to the little kids as well. Our orthodontist will also treat skeletal malocclusions and irregularities of the teeth with braces. And then we'll also work on that palatal expansion that we need to do in preparation for these kids that need a bone graft. Next, we have our oral maxillofacial surgeon who works closely with the orthodontist and plastics, so our team. But our surgeon determines the timing of that alveolar bone graft through a series of panoramic x-rays and CBCT scans, which stands for cone beam CT scans. He will also be he's that surgeon that will perform orthognathic surgery, also termed as jaw surgery, to help normalize any jaw relationships or discrepancies that these patients might have. We next have a speech and language pathologist who's responsible for evaluating speech concerns and treating with proper techniques. She assesses the velopharyngeal function. She'll provide expertise in increasing or decreasing speech services for optimal speech outcomes. She'll also help identify resources within the community. A lot of the times we have patients that come from small towns. They really don't have access to like private speech therapy or not. So she'll kind of tease out and see who, which providers are close to them and how we can help them in that manner. And then we have the plastics and reconstructive surgery side, which is my side. But we're responsible for the surgical repair of cleft anomalies, that velopharyngeal incompetence, and insufficiency, along with their final revisions that we focus on. Our goal more so is to aid in promoting the aesthetics, eating, and speech outcomes for these patients as they grow. As far as prenatal consults, we are one of the 2 providers, so we'll get a lot of referrals from this hospital as well. We get them everywhere, but the prenatal consults, we'll just meet with the family just to kind of reassure them, calm them down a little bit, let them know that everything's going to be okay. So we'll answer all the questions and just give them insight as to what a child having a cleft lip and palate might involve. We next have our pediatrician, who is our team director. So he just assesses overall health condition, the feeding, nutrition, and growth, makes proper referrals. It's actually really nice to have him on board because sometimes families will come in like, hey, I have this rash, or my son has this rash, and he'll just go on in and treat it. So saves them an office visit. Then next we have our feeding therapist who assesses overall feeding to promote growth. She is the other provider that meets during these prenatal consults to educate on what to expect with feeding in bottles. So she definitely plays an important role during that initial consult because a lot of the families, I will say, get really nervous about the feeding aspect when it comes to cleft lip and palate. So she helps reassure them that everything will be just fine. And then we have our social work. So she helps support with the coordination of all types of services. So these examples would include insurance, funding that might be available within Boys Town, referrals to schools. Sometimes we'll refer to early developmental network. She'll help obtain records and figure out their IEP plans, their IFSP plans. And then transportation, that's actually a big one that I've noticed over my time. A lot of these small towns don't have the means to get to us, and we have to see these patients. So she'll kind of figure out if Medicaid can approve their transportation costs, or sometimes we'll provide CAP vouchers for these families as well. And then we have our registered nurse who assesses overall health condition, works closely with our team coordinator, fulfills honestly all the aspects within the specialty clinic. We then have our team coordinator and nurse case manager, and she's responsible for coordination of all the clinic appointments. She plans our weekly team meetings, compiles all these craniofacial letters that we send to families and PCPs, and then any appropriate referral. I will say the registered nurse case manager, they are the backbones of our clinic, because honestly, without them, we wouldn't get our job done. There's a lot of tedious work that they do that no one knows about, but they work with all the providers, honestly, to help manage a patient's care. And then we have other important members. These team members are not necessarily in our clinic. but we will send them off on a referral basis if need be. So we have ophthalmology, neurosurgery, psychiatry, psychology, and then gastroenterology as well. So now we're going to kind of switch gears into genetic syndromes. I'm not a geneticist. That's honestly way over my head, but I know enough. So I got in touch with our geneticist to kind of give me an idea, like what are the best syndromes to discuss with in relation to cleft lip and palate. So just know, if a patient has a genetic syndrome and a cleft lip and palate, it just makes their care a little more involved or complex. So that's why our geneticists play a very important role. But just to give you a brief overview with regards to like differences when it comes to syndromic and non-syndromic or isolated events, about 10 to 15% of patients with a cleft lip, with or without a cleft palate, actually have a related syndrome. 40 to 50% with a cleft palate alone have a syndrome as well. When it comes to isolated events, so isolated cleft lip with or without a cleft palate occurs in about 70% of cases. So it's a lot of cases that we see. Isolated cleft palates account for about 50 to 60% of cases. So we'll kind of just go overview just a few syndromes here. So the first one we have here is DeGeorge syndrome, also known as 22q11.2 deletion syndrome or velocardiofacial syndrome. This happens in about 1 in 4,000 patients. Some craniofacial concerns with this syndrome. Most of them have a cleft palate or that submucous cleft palate, and then VPI, which stands for velopharyngeal insufficiency or incompetence. So I'll give you the difference between the two. So insufficiency refers to abnormal structures within the velopharyngeal valve, whereas incompetence refers to inadequate movement of those velopharyngeal structures, or it might be associated with some neurological disorder. This VIP component with this syndrome is very important within our clinic. So we have to monitor their speech development, especially with those people that are patients that actually have a cleft palate repair. The next we have is Pierre-Robin sequence. This was formerly known as Pierre-Robin syndrome. This name was changed due to like a single malformation in utero that led to a series of events. So hence the sequence. So this happens in about 1 in 8,500 to 20,000 patients. So specifically with these patients, we really worry about upper airway obstruction along with feeding issues. There's a classic triad with Pierre-Robin sequence and classic representation. So the first one is micrognathia, having a small hypoplastic mandible, small jaw. You have glossoptosis, which is where your tongue gets pushed far way too back. And then you have a U-shaped cleft palate. Now there are 3 different grades when it comes to Pierre-Robin sequence. The first 2 grades, 1 and 2, you can treat with non-invasive measures, whether that be NG feeds or prone positioning. But when it gets to grade 3 is when it's very severe. These babes are under respiratory distress, they cannot feed well, which then leads us to immediate surgical intervention with what we call a mandibular distraction. And our plastic surgeon is the one that usually will perform these procedures. So the goal of that is more so to open up that airway and move that jaw forward so that these babes can breathe. So the craniofacial concerns with this would be that cleft palate, which eventually will get repaired, and then that micrognathia and that jaw growth that we monitor these patients. So next we have Stickler syndrome. So this is closely associated with Pierre-Robin sequence. So about half of the patients with Pierre-Robin sequence have Stickler syndrome. This syndrome is associated with, it's basically a collagen disorder that affects ocular, orofacial, auditory, and has some skeletal manifestations as well. It happens in about 1 in 7,500 to 9,000 patients, but within this clinic specifically, all those craniofacial concerns, that cleft palate that they can have, the micrognathia that they can have as well, and then audiology and ophthalmology. These patients are at high risk for hearing loss, along with risk for eye abnormalities. And then the last syndrome we'll talk about is van der Waals syndrome. This occurs in about 1 in 40,000 patients to 100,000 patients. Complications involving this syndrome is typically just developmental delays and more so speech delays. A classic sign of this syndrome, we see lip pits. So basically indentations along your vermilion, which is your lip. These lip pits pits can be surgically removed just to kind of help prevent increased saliva and mucus from forming. But the craniofacial concerns we have with this, these patients tend to have a cleft lip, they also have a cleft palate, and then their teeth development. So we focus on that oral hygiene because we have concerns with hypodontia and then enamel hypoplasia as well. So then now we'll kind of go into more the pre-surgical intervention techniques that we can do. So the first one is called a nasal alveolar molding device, also known as the NAM device. So this is a pre-surgical device more so to help improve that cleft deformity. It really decreases the width of the cleft lip and the gums, along with improving the shape of the nose and gum alignment. So that photo that you see here, it's an intraoral appliance with those nostril prongs. It looks very uncomfortable, but these babes can adjust to it. Most of them can do. Studies have shown that when this is initiated early in life, like as early as 2 to 3 weeks, we see a lot of improvement when it comes to that alar symmetry, comellar lengthening. It centralizes that premaxilla, which is that tissue and that gum tissue. It also just works on that nasal tip projection that we would want. The goal ultimately is for this to kind of decrease that tension within that muscle and soft tissue in preparation for lip surgery. So on average, I'd say the use of the NAM is roughly around 3 to 6 months time. So we refer to a prosthodontist at Nebraska Medicine. So once he gives us the green light and says, all right, this patient's ready for lip repair, and then that's when we intervene on our end. Now, there are a lot of craniofacial teams around the US. I don't know if that's a standard approach for them. However, at least at Boys Town, our plastic surgeon usually utilizes this for bilateral clefts if they're very, very wide. So like I said, steps involved, like I said, referral to prosthodontist. So we'll kind of see the patient first to determine the severity. Sometimes our plastic surgeon can just repair the bilateral cleft lip if the cleft isn't as wide as we think it is. So if they are a candidate, they'll see Dr. Mark. He then makes mold impressions of the palate. He makes a custom device that's held by small rubber bands and taping to the cheeks. The problem with this, I will say, is that's a disadvantage, is that they're weekly and bi-weekly adjustments to the mouthpiece and tape until that lip repair. We had a patient from North Platte, so that's what, 4 hours away. They were very determined. They came weekly, bi-weekly, but they did it. So some families can't do it. We recommended it maybe in a couple patients, and the parents were like, I stopped it, I took it out. It's not working for us, so, which is okay. We work with that. So definitely, like, it's a time commitment from parents. Feeding can be resumed with a specialty bottle. That's one of the things that parents would like to know, so no issues with that typically. So here's a photo that I found from the craniofacial team in Texas. So you can kind of see the before and after of this bilateral cleft lip and palate when they use the NAM device. So you can see that tissue in the middle, which is your prolabium and premaxilla. See how much that protrudes out significantly. After that NAM device use, it kind of just tucked everything in, made it a little easier so that way when the surgeon does the actual lip repair, there's not so much tension per se. And then this here, we have a prenatal book that we show families of Dr. Miller's work of all the different types of clefts that he's repaired. So this is just an example of one of them here, but you can kind of just see the good outcomes of that after her lip surgery. So the next pre-surgical intervention is called a dynacleft taping. So really, it's the same concept as the NAM. The goal, once again, is to lessen that gap and reduce that tension in preparation for cleft lip surgery. So the prosthodontist, Dr. Mark, will usually help determine which intervention is most helpful, either use of the NAM or with taping or dynacleft taping alone. So the benefits of this, it's simple and easy to use. Should I just dismiss it? Okay, benefits of this. So simple, easy to use, less office visits, it's non-invasive, there's elastic strips, it helps just expand and contract with an infant's movement just for comfort. So we don't use this all the time, but just know that this is available and some other teams might use this as well. Now for the fun part, the surgical side of things. Okay, so now we're going to talk about the surgical intervention and then postoperative care. So now you kind of get an idea of what these babes have to go through their life. So in some instances, per surgeon's discretion, we might recommend what we call a premaxillary repositioning. And this is typically with those bilateral clefts, if they have those really wide bilateral clefts. So as you can see in the photos here, remember that prolabium, that premaxilla, that tissue that really protrudes out, similar to the NAM photos I showed you. I like to think of this as like a staged lip repair. So the goal of this is to decrease tension. Once again, I'm going to kind of reiterate that a lot. The procedure that we perform is what's called like a lip adhesion. So Dr. Miller will just use dissolvable stitches to kind of place everything where they need to be. And then we let those stitches dissolve, but it just really just kind of helps push everything back. The pros, less work for parents. They don't have to come for those weekly visits. It's kind of like a one and done thing. And then once we do this procedure, a couple months later, we do the actual lip repair. The only disadvantage of this is that a patient needs to be under anesthesia when they're that young. But the post-op cares are very similar to the lip repair, which I will be discussing next. So usually, the first surgery a child will encounter is this cleft lip repair, which is what we do to perform that cleft abnormality. So literature states what we call that rule of 10, which we consider in preparation for surgery. So these are as follows. Patients have to weigh roughly 10 pounds, doesn't have to be exactly. They have to be at least 10 weeks of age or so that 3 months of age is when we typically do it. And then they should have a hemoglobin concentration of 10 milligrams per deciliter. So the reason for this is not more so for the aesthetic outcome. We just want these infants to grow and have allow that lip musculature to grow. You know, ensuring that all of these three requirements will ensure that these patients are growing appropriately and knowing that they'll have just good heart and lung function when they're under anesthesia. So there are different techniques usually with cleft lip repairs, but the most common technique is what we call the rotation advancement flap. And what this involves is making proper incisions along the cleft edges and then repairing these in 3 layers. So there's a lot of stitches that are involved with the repair. So we have to repair the mucosal layer first with dissolvable stitches, followed by the muscle layer, which is your orbicularis muscle layer with the dissolvable stitches, and then the skin layer with stitches that will need to be removed a week later. So some things to consider when we do these procedures. Remember, these kids are at high risk for hearing loss. So if they need BMTs, which are ear tube placements, we'll do that in conjunction to save an anesthetic. So we'll perform that typically. We have what's called ABR testing, which is auditory brainstem response testing. Sometimes audiology can't get the information they need, so we'll do it under sedation as well. So we have more diagnostic information. When it comes to those microform cleft lips, those hidden cleft lips or occult cleft lips, sometimes we just monitor versus doing surgery. Sometimes the risks weigh out the benefits, so we kind of just wait and see because we don't want to just put a baby under surgery just to put them under surgery. So we just kind of monitor their growth with regards to that. So how do we care for these patients? Well, they typically just stay overnight, more so to monitor feeding and pain control. They have, are you guys familiar with these like Velcro elbow splints? Have you seen those? Oh, well, they're very uncomfortable, but they have to use them for 3 weeks just to avoid fingers in the mouth and touching that surgical site. Full liquid feedings, we recommend syringe feeding for 2 weeks. So we provide them with medication syringe with a plastic tube at the end, and they have to feed that way. So that's not fun all the time as well because they're used to their pre-op specialty bottle. But after the 2-week mark, they're pretty well healed for the most part. We allow them to use their bottle thereafter. We place some Dermabond glue, that surgical glue, over that incision site as an added protection to that site. And then these patients typically have nasal stents that are sutured within their septum, and then that gets removed post-op as directed by our surgeon. And then they have to come back to the OR in 1 week's time under mask anesthesia to remove those stitches. I think way back in the past, before me, from what I heard from nurses, they used to do them in clinic, and you can imagine a screaming baby, everyone's sweating, not having a good time. So Dr. Miller decided that it's better to do it under mask anesthesia. It's a lot safer for everyone. Okay, so potential complications from this. As with any incision, any surgical incision, wound dehiscence. So that can happen. A widened scar as these kids grow. Sometimes their scar gets a little wide, but we can always do revisions thereafter. There's what's called hypertrophic scarring, which is thickened scar tissue. This we intervene as soon as we can. We'll advise on scar massage with vitamin E oil. They don't like it, but Parents will do whatever they can to make that scar look better. Sometimes if that's not enough, we'll do what we call steroid injections. So we put them under mask anesthesia, inject some Kenalog in there to help soften up that scar. Sometimes there's significant nasal ala flattening, so which is this part of your nose. The cartilage in your nose is very, very flimsy when you're so young. So we use the nasal stents for that reason, to kind of help shape the nose. But sometimes if you just take them out too soon, it can flatten out again. So that can happen. And then difficulties breathing through the nasal stents. I've seen patients, maybe 1 or 2 patients, we recommended using it for a good month. So you can imagine these babes not being happy. So sometimes we'll just remove it sooner if we need to. So here are some examples I'm going to show you. This is from that prenatal book that we show families of Dr. Miller's work. So here's an example of that bilateral cleft lip and palate. And this guy, I don't think we didn't do like a NAM device on him. He didn't need to. His severity wasn't as bad. And then we have what's the unilateral cleft. So the left side is the complete, and then the incomplete on the right side. So you can see good outcomes from that surgery. So the next surgery that we perform, so the cleft palate repair. So we perform this more so to repair that cleft abnormality and help with feeding and speech outcomes. We tend to do this surgery roughly around 9 months of age, and the reason for that, we want that palate to heal in time. It takes about a good month or so for that mouth to heal really well, but that gives us enough time. So once they heal, these kids learn to speak roughly 1 year of age. So we want to set them up for success. So that's why timing is kind of essential. But once that palate is repaired, as you know, the palate plays a huge role when it comes to making certain sounds. So we focus on that. The common technique what we use is a 2-flap palatoplasty. And this too is also similar to that lip repair, repaired in 3 layers. So we have a nasal layer that we repair. We have the musculature and that soft palate that we repair, followed by that mucosal layer. Things to consider is the ear tubes again. Sometimes these patients need to get their ear tubes replaced or not, and then that ABR testing too. So whatever we can to combine as much as we can under surgery, this is what we do. So here's a quick snippet, very short version of how the cleft palate is repaired. I tried to make a video years ago, and you can just imagine being in a sterile field holding a scope. It was very hard. This is a 2-hour procedure, so it was a lot of movement per se. So this is the best that I got, okay? But you can get the idea. So the top 2 photos, okay, shows incisions that are made along the cleft edges. The bottom photos are what's called the mucoperiosteal flaps that we create on both sides. So this is where we actually relieve tension within tissues, so then we can successfully close that palate. So similar to the lip, right? The 3 layers, we then first start to close that nasal mucosa layer, followed by that musculature, and then that oral layer, and they're all dissolvable stitches. And then that final step on that bottom, we place and suture in what we call zero-form palatal packing, just to add protection to that site, but that gets removed before they leave the hospital. So how do we care for these patients? They stay 1 to 2 nights, typically 2 nights, to monitor their feeding, pain control, and airway obstruction. They can resume their specialty bottle that they use preoperatively. Sometimes, give or take, I've seen both ends of the spectrum, but sometimes they're just not ready for the bottle. Sometimes we'll just offer using the syringe feeds that they used before, just so that we know they're getting something in orally. They'll have a nasopharyngeal airway that gets removed post-op day 1 if SATs are stable on room air. And then that, like I said, that zero-form packing, that suture to the roof of the mouth, that gets removed before they leave. And then they have those uncomfortable elbow splints again for another 2 to 3 weeks. So complications from the cleft palate repair. Once again, wound dehiscence, which then leads to what we call palatal fistulas. And this can be anywhere. This can be along the hard palate, the soft palate, or both hard and soft palate. This is something that we don't get worked up about because they're still healing. The mouth actually heals pretty quickly. So we don't rush them off to surgery if we notice like a 1 millimeter, 2 millimeter fistula. We just monitor it. Over time, we tend to see that these fistulas kind of shrink over time. Now, if a fistula gets bigger and bigger and it affects feeding and speech, then that's when we decide to intervene surgically. So the next surgery that a child might go through is what we call a pharyngeal flap. So this surgery is performed more so to help improve speech outcome. And that diagnostic term, that VPI, that velopharyngeal insufficiency and incompetence is what this refers to. I'd say about 10 to 20% of patients that undergo or have a corrected cleft lip and palate usually have this P-flap or pharyngeal flap done. So that VPI, it's acquired due to abnormality structurally, causing that air to escape, which then results to inadequate closure of that velopharyngeal valve when we speak. So what we see with these patients, they are very hypernasal and incomprehensible. The most common cause of this usually is just having a short palate, which means that, so here's your posterior pharyngeal wall, here's your palate, and when we speak, that soft palate just doesn't quite move, and it's just, there's a very big gap here. So when there's concern for VPI, we'll do some other diagnostic testing. So one would include nasoendoscopy, and this is a flexible scope that's inserted through that nasal passageway, which then can give us better visualization of the structures within that velopharyngeal gap. We have speech language pathologists there as well to kind of work on speech samples during this time, and we can kind of determine whether or not VPI is indicated. And if so, we typically will refer to get this done or recommend this pharyngeal flap. There's then what's called nasometry, which is what our speech and language pathologists will do as well. But that's just further diagnostic information on her end that shows if there's audible nasal air emissions when they do speak. So things to consider is sphincter pharyngoplasty. Sometimes these P-flap procedures aren't enough and there's persistent hypernasality. So we noticed during a nasoendoscopy that their lateral wall movements, there really isn't much. So when they speak, that's why the air keeps escaping when they speak. So we'll kind of recommend what we call a sphincter pharyngoplasty. There's also what's called an autologous fat injection, where it's basically liposuction from your abdomen that we get transferred to that soft palate for extra support to prevent that hypernasality. As far as timing goes, surgery is usually done childhood years or greater, just all dependent on their development with speech. But the youngest I've seen it done, we've done it like at 3 years of age. So here's another quick snippet of how the surgery is performed. It might be easier to refer to the bottom photos. So we make an incision along that posterior pharyngeal wall. We make an incision on that soft palate. You remove some of that tissue and place it onto that soft palate with dissolvable stitches. Very simple procedure with lots of great benefits when it comes to speech outcomes. So how do we care for these patients? They stay overnight for feeding, pain control, and airway obstruction. They too have a nasal pharyngeal airway. We get that removed post-op day 1 if SATs are stable on room air. They have to be on a soft diet for a good month and then no vigorous activity and speech therapy for 4 weeks. So if you can imagine having a toddler going through this, we really can't do anything. We have to lay low. It's a little difficult for parents sometimes, but they get through it. So complications with this. Number 1, airway obstruction. You know, we're taking tissue and really kind of blocking part of your airway. So sometimes these patients will snore. Sometimes they'll have a little mild OSA, obstructive sleep apnea, which is common, but that snoring tends to get better. So wound dehiscence, which I've seen, some families can't control their children from yelling so much. So I've seen it happen where they're constantly yelling and the stitches just popped open, which then these patients will develop a palatal fistula to that soft palate. Sometimes there's no improvements with the speech, like I said, with that sphincter pharyngoplasty that we'll do. We'll see some undercorrection, so there's continued hypernasality, or there can be overcorrection and you can see hyponasal speech with these kids. So the next surgery in line is that alveolar bone graft, okay? So that alveolar bone, which makes up that gum ridge, okay, is a thin layer of bone that forms sockets around your teeth, right underneath that gum tissue. So the cleft prevents the teeth from growing properly. These alveolar bone graft repairs that cleft and that gum ridge to help stabilize that bone to provide support for that teeth to actually grow into. So timing is very essential when it comes to this. It has to be accomplished prior to canine eruption. And how do we determine that? We do through a series of panoramic x-rays or cone beam CT scans. There are two ways that we can do this procedure, and there's no preference between the two. It's whatever the parents would prefer. But we do what we call a bone morphogenetic protein, also known as the BMP. So this is a synthetic bone that we use, and this is just performed by our oral surgeon. And then we have what we call a hip autograft. So we take bone from that iliac crest, but this needs to be done with the oral surgeon and plastic surgeon. The surgery is usually performed around childhood years or greater. The range since I've been in this clinic, I've noticed it happen roughly between 9 to 12 years of age. Once again, it all depends on the timing of that canine eruption or when that canine is about to erupt. Most often, these patients need palatal expansion, so we do need our orthodontics as part of their plan of care as well prior to surgery. So here's another good outline of how this procedure is completed. So kind of just looking from left to right, top to bottom, make your proper incisions along that mucosa lining, along that gum ridge, so now you can access that bone. Most often that these kids can have an oral nasal fistula, so we have to repair that first. And then we place that bone. We either place that synthetic graft or that hip graft to fit nicely within that cleft. And then lastly, you just kind of suture those mucosal flaps again with dissolvable stitches. And then here is just another photo of this procedure. It might look a little better with color. Kind of see how this is done. Okay, so post-op cares for this procedure. So if parents opt for that BMP route, these patients get discharged the same day. So it's a nice 1-hour procedure. They go home. If they choose a hip autograft, this is when we recommend they stay overnight to monitor for pain control. So they typically stay 1 to 2 nights. Our oral surgeon will prescribe what's called an on-cue pump to that graft site, which is just numbing medicine that gets delivered along there. And then 2 days later, they can just take it out on their own. These patients have to be on a full liquid soft diet for a good month, no strenuous activity for 6 to 8 weeks, and then educate on that oral hygiene as well. So what are some complications from this procedure? Well, sometimes, so after a bone graft is completed, 6 months later, they have to do another CBCT scan to determine whether or not the bone graft has taken or not. If not, we might notice some inadequate bone formation. So in these instances, our oral surgeon might recommend regrafting entirely or augmenting that bone or adding a little more bone in that area. So that wound dehiscence can happen. That oral nasal fistula that they have, that might persist too. And then sometimes bone exposure. If that mucosal lining doesn't heal well, you might notice some bone. So orthognathics, also termed as jaw surgery or Lefort osteotomy. So this is one of the final surgeries that we do to help correct any malocclusion or mid-face protrusion. When it comes to surgical correction of clefts in general or cleft palates, that scar tissue that they develop and as they grow can inhibit jaw growth, resulting in what we call mid-face protrusions, where this upper part of your face is kind of just pushed back a little more. We use cephalograms to monitor that jaw growth and growth cessation. So they're basically x-rays. These are initiated by our oral surgeon as well, who then obtains these every 6-month intervals until they're done growing. But surgery essentially involves moving the jaw, correcting that malalignment and placement of like titanium hardware. We usually perform these surgeries at skull maturity, so teenage years typically. And then our oral surgeon will also work in coordination with our orthodontist because these patients will go through pre-orthodontic treatment months before surgery. And they'll likely continue that thereafter as well as part of their care. So post-op cares for this. This requires a 1 to 2 night inpatient stay. Sometimes their jaws get wired shut completely. Sometimes we have to use rubber bands, but we have to avoid wide mouth opening to avoid complications from that surgical site. These patients have to be on a full liquid soft no chew diet, no strenuous activity again for 6 to 8 weeks, and then swelling is to be expected, so ice pack is going to be their best friend. So this is kind of a good photo showing the different malocclusion types that we monitor and deal with to determine recommended Lefort surgery. So This is all in relation to the location of your molars. You can kind of see them highlighted in blue, but we'll go over all of these. So the first one on the left, you can see that that maxillary molar is slightly posteriorly positioned to that mandibular molar. So that's considered class 1 malocclusion. That middle photo, you can see a retrognathic profile where that jaw is kind of pushed back a little bit, that mandibular jaw is pushed back. Your maxillary molar is in line or anteriorly positioned in front of that mandibular molar. In these cases, you just refer to them as overbites. Class 3 is a prognathic facial profile where you see maxillary molar is posteriorly positioned to that mandibular molar, and then you tend to see an underbite in these patients. And this is just a 3D photo showing that titanium hardware that's used along with the braces that we keep in as well, but all dependent on the severity. Sometimes some patients might need to do distraction and just whatever Dr. Disa decides to do, but not oftentimes that happens a lot, but usually this is the typical view of what we see. So potential complications. Sometimes there are sensory changes. So post-op, some patients will complain of numbness in the cheeks and the lower lip. There's always potential for permanent injury to those nerves, but that tends to get better. But I'd say that's probably one of the number one things that they do complain about. And then it can exacerbate any existing UPI. So when you move your jaw forward, you're moving structures forward, right? It might make that hypernasality worse in some patients. So we have to monitor these speech changes before surgery and after surgery. And then sometimes painful or infected retained hardware. Sometimes they can get an infection, and if so, we just find the culprit and then we just take them back to the OR to remove that certain piece. So the last stage of surgery. So we like to wait for surgery until a patient reaches skeletal maturity, okay? Similar to the jaw surgery. We then intervene with what's called the cleft septorhinoplasty. So this is performed to correct any nasal deformity and just restore that symmetry for these patients. Teens face such an impaired aesthetic appearance. We just want to set these kids up for adulthood, right? Because kids are mean nowadays. So by doing this, we really reinforce shaping that weakened cartilage, that nose, and just try to do our best to create more symmetry. Oftentimes with cleft lips, cleft palates, you have a deviated septum. So we'll fix that in order to kind of improve their respiratory function. Some things to consider. So we perform right after orthognathic surgery because orthognathic surgery can really change your profile. And then along with that swelling that comes with jaw surgery. We'll also consider lip revisions as well. If there's anything we can tweak with the lip, we'll fix that too. We offer what's also called alloderm graft placement. So just think of that as a permanent lip filler. Some patients have a deficient thin upper lip. So we'll try to make that a little more proportionate as well. The final outcome post-surgery honestly can take 6 to 12 months because there's a lot of swelling that can be involved with this type of procedure. So if there's other tweaking that we need to do, we certainly can do it thereafter. So how do we care for these patients? Nasal stents. So they start with nasal stents when they're little babes. They kind of end with nasal stents before entering adulthood. But those get removed 1 week post-op. But it's probably my favorite when I remove those because they can breathe so much better. I feel like I made their day, so it's quite rewarding. They have drip pads just for any drainage that comes down from their nose. Bruising, significant bruising and swelling is normal, but that gets better usually in the 1 week time frame. Diet is tolerated, so no restrictions with that. No strenuous activity or heavy lifting as well. And then we just say no nose blowing, coughing with that mouth wide open because we don't want to disrupt or add any pressure to disrupt that surgical site. So complications after this. So bleeding can occur, obviously. Difficulty breathing through those nasal stents. So those are a nuisance. Like I said, once I remove those, everyone is so much happier. Wound dehiscence, and then relapse of that nostril. That nasal alastole can kind of come down a little bit after we remove those nasal stents. So we just let them heal over time, see how they do in about that 6 to 12 month mark. If we still need to tweak something, we certainly can as well. And then this is an example photo, one of my favorite patients. I know her mom really well too. But this actually will show you a good photo of her jaw surgery before and after. So you can kind of just see based on her profile how much that has changed significantly for her. So having a cleft lip and palate doesn't preclude you from doing anything in life. So we do have to reiterate and reassure parents of that. So a lot of famous people have a diagnosis of cleft lip and palate. So just to give some examples here, we have Peyton Manning, who has a cleft palate, Doc Holliday with a cleft palate, partial cleft lip, Joaquin Phoenix, which you will all know, that microform cleft lip, and then Cheech Marin, who has that cleft lip as well. And then this is the organization that we're accredited by, ACPA, the American Cleft Palate Craniofacial Association. If you need more information, this is the website that I refer to for all our prenatal consults, rather than Googling different things. But there's a plethora of information on here. If you have questions for me that you would email, you can always email me too.
So I'm just curious, like when you guys do each of the surgeries, like with their babies, do you monitor like weight loss much or?
Yeah, so we've had some instances, actually I was telling you guys about this earlier, just kind of briefly, but because a lot of families think like, we have to fix the lip now, we have to fix the palate now. But if they're not feeding well, we will not intervene because they're not going to do well post-operatively. And from an anesthesia perspective, right, we need to make sure these babes are growing and doing well. Post-operatively, I feel like they tend to do better. So we obviously do the weight checks and so forth with each visit. We typically don't have a problem. Sometimes we'll have some patients that don't feed well. So that's when our feeding therapist will come into play to kind of figure out what's going on, per se. But yeah, the weight is a big thing for us, especially in the first few months of life. Because if they're not feeding well, we're just going to kind of push off the surgery so it can delay their timeline. That makes sense.
Any other questions?
I'm curious, does insurance always pay for the later plastic,
Yeah.
cosmetic stuff?
I do. I've had some where I had to do peer-to-peers, but most of them do because their diagnosis is cleft lip and cleft palate. So most often I probably had maybe a handful over the 6 years I've been working where I had to fight it. Yeah. It's more so I think like the spinal revision, like the lip allograft graft, like that's what sometimes like, oh, they don't need that, it's not a functional thing. But it's like, well, they couldn't help it. This is what they were born this way. So yes, I try to fight it. Advocate for these patients.
I'm Amanda Leverchek. I am the feeding specialist here in the NICU and a speech language pathologist. So I'm sorry I missed the beginning of your presentation. I just wanted to review a little anatomy. So obviously I deal with like the bottle feeding aspect of cleft lip and palate, mostly palate, but just as a review. So here we have like the soft palate, and that needs to move up and back towards the pharyngeal wall so that they don't have any nasal regurgitation. Here's the epiglottis that folds down over the airway so that things don't go into the airway, but they go into the esophagus. And here we have a nice hard palate, soft palate, and all the good structures that we need to swallow. Okay, so suction and compression are the two main things that are required for a baby to be able to transfer anything via breast or bottle. So infants that have clefts have a difficult time feeding because there's basically a hole in the system. So I always compare it for parents to, if you think about a straw with a hole in it, like you get a tiny bit out, but mostly you're not really transferring any volume. So they have to just compress with their jaw. They can't create suction at all. So how does this impact feeding? So there's poor or absent intraoral pressure, aka suction. And so the compensatory muscle movements affect all stages of the swallow. So the oral, pharyngeal, and esophageal stages. These babes expend a significant amount of energy during the act of feeding. And I think this statistic is really kind of crazy. So the average, they average 109 sucks per minute, which is compared to infants without clefts who average 75 sucks per minute. So they're just really using a lot of energy to feed. So feeding is really a baby's exercise anyway, but they're like on turbo mode. And they often swallow more air. So it's really important to burp them more frequently, because if they're swallowing more air, their bellies feel more full. And so then they're not apt to eat as much as they need. And so the frequent burping is really important as well. So they underuse their geniohyoid muscle, which I have here for reference, and their mylohyoid muscles during the oral phase, and thus they have an extended pharyngeal phase. So this is all compensatory to help them feed. So things you might notice are audible swallows, which is very common, pharyngeal wetness, and then throat clearing as they are doing compensatory strategies. Obviously, when we're feeding, we're going to be looking for stress cues. So furrowed brow, wide eyes, tension in extremities, finger splays, facial grimacing, all those things. We just need to make sure that they're comfortably feeding and they're not super stressed out. Otherwise, we need to look and see what we can do to make it a better feeding experience for them. So feeding considerations. We really want to feed these babies in an end face or an upright position. We're going to have gravity help us with moving the bolus down through the oral cavity and down the pharynx into the esophagus. And then you're going to direct the nipple towards the side of the mouth that does not have, basically that has more bulk for better compression. Obviously, if there's not a lot of bulk there, you can't really direct that. And I often find that the bottle will slip over into the open area, and parents will kind of prefer that. But I usually try and have them start out where there's more bulk so that they can get a good compression and get a little bit more volume from the bottle. It's very common for these babies to experience nasal regurgitation, because remember that that anatomy that I was showing you, they don't have that soft palate to close off the nasopharyngeal area, and so milk can go up that way. That's another reason why we like to feed them in an upright feeding position as well. Like I said before, frequent burping, and then I guess I asked you about this, but weight checks. So sometimes weekly with the pediatrician, with the goal of returning to birth weight within 2 weeks. So just making sure that and obviously this is all before surgery, but just making sure that they're gaining good weight so that we know that they're feeding well enough to grow. So there's two types of bottles that can be used. There's a feeder-led bottle, and then there's also an infant-led bottle. So basically an infant-led feeding system is one where the infant moves their jaw in a vertical motion to compress the nipple. And then I'll show you examples of these, but there's a one-way valve that converts the bottle from a suction and compression system to a compression-only system. And then the infant gets milk only when they are the one actively moving their jaw to compress the nipple. And then the infant is able to control the flow of milk, because when they stop sucking, the milk stops going. And so this is obviously my preference because the baby's the one in control. And then there's a feeder-led system. So again, I'll show you an example, but this is when the feeder is squeezing the milk into the infant's mouth when the infant is attempting to suck. The feeder is the one that is transferring the milk, as the infant is the passive recipient. And the problem with this is that it can be really difficult to coordinate your squeezing with the infant's compression of the nipple and all that stuff. So it just can be, I don't know. I don't feel like I would personally like someone squeezing milk into my mouth when I wasn't necessarily ready for it. So this is not my optimal choice here. So there's a variety of bottle types, as you can see here, and I'll kind of go into detail with these here. So I don't have an example of this one, but there's the Mead Johnson Cleft Palate Nurser, and this is a feeder lead system. Some of these are a little bit older, but you still find them around. So this is one where it's a very soft-sided bottle, and the feeder just squeezes the milk into the baby's mouth in conjunction with the infant sucking. The nipple is a cross-cut nipple, which kind of terrifies me, to be honest, because it's a cross-cut nipple. When you think about like a regular nipple, it's just kind of like a really small pinpoint hole. A cross-cut nipple is an X, so it really allows for a lot of milk to go into the baby's mouth. The one pro is that they're cheap. So you do, every now and then see these out there. This next bottle is the Pigeon. You could probably speak to how often you see different bottles in the clinics, but this is the Pigeon bottle. So this is an infant-led system. It does have a vertical slit in the nipple that opens when the infant compresses, and then there's two sizes of nipples, and there's no flow rate difference in these. They're just like really for the size of the cleft. So this one is bigger, this one is a little bit smaller. So on the nipple, there's a little notch here. This notch goes in line with the nose. And then you have to prime the nipple. So you squeeze the nipple, turn the bottle upside down, and then it fills the nipple. And I can pass these around too, but so where the notch is, you'll notice if you feel the nipple, it's harder on the top and then softer on the bottom. So it's just kind of their way of creating a little bit of a hard palate, I think. But then, yeah, the infant just compresses and here you have it. So let me see these, but you can pass it back. And they are pricey. I think, I want to say they're like $30 a piece. $30. Yeah, yeah. Okay, and then this one is the Haberman. So this one has been around for a long time. This is mostly, I consider it a feeder-led system, but in some ways it can be infant-led. It's a squeezable nipple for the feeder to transfer milk into the infant's mouth with each suck, and then markings around the nipple indicate the flow rate. I'll go over that. So basically, you prime the nipple, so squeeze the air out, turn it upside down, and it fills. And then on the bottle, there's different lines, the longer line, a medium line, and a short line here. And that's just like fast, medium, and slow flow, basically, depending upon where you line the line up in coordination with the nose. And then the feeder is the one that squeezes the nipple, and then the milk goes into the infant's mouth. So I am not my personal opinion, I'm not a huge fan of these, just because, again, like, it's not the infant doing the active work of transferring the milk. But I also feel like it can be really difficult for parents to know like how hard to squeeze, how long to squeeze, all those types of things. And then it can sort of be an infant-led system if if you kind of are really trying to get like minimal amounts in the infant. So I have used this in the past, like maybe once or twice a while ago, just to get the infant to try and take very small amounts. If it's somebody that like, I'm trying to even think what we were using this bottle on, but maybe someone that, or a baby that has like a little bit of an oral aversion. If you want just really small amounts to go into the baby's mouth, then you can use something like this. Okay, and then what we use here, and I think probably what you guys see most, is the Dr. Brown specialty feeder. So this is an infant-led system. It has a one-way valve, that's the blue that you see up there, that fits into the nipple. And it allows the infant to compress and transfer milk with their natural rhythm and compression of their sucks. The nice thing about this is that you can have all of the different flow rates for this bottle. So you prime the nipple again, just like you did with the pigeon, turn it upside down in the Haberman, and then the infant would just compress and it comes out. But like I said, you can use like an ultra preemie, a preemie, all the way up to a level 5. So it's really like the whole kind of gamut of baby's feeding abilities with this. And the only thing that makes this bottle look different, which I think a lot of parents like, is this blue valve. So it doesn't necessarily, when they're out in public, look like they're feeding their baby with a weird bottle, which, you know, can be important to parents as well. And what Dr. Brown's is coming out with, which they sent me one, which is very exciting, is a new wide base with a valve. And so I feel like this is going to be really good for the right patient. If they aren't really super successful with this bottle, it's nice to know that there is a wide base bottle out there that is coming out. They told me like within the next year, that they can try, that has maybe a little bit wider cleft. I'm really anxious to try this with a baby. So did you know these were coming out? Yeah.
Contact them.
Yeah. She only sent me one, so I guard it with my life. Also, the nice thing about the Dr. Brown's is that they're moderately cheaply priced. So here in the hospital, if I meet with them prenatally, I give them, we have what's called like a Dr. Brown's Cleft Palate kit. And it comes with 3 9-ounce bottles, 3 4-ounce bottles, a bunch of extra one-way valves. They all have level 1 nipples on them. I'm trying to think, those little blue brushes to help clean. But it's nice because then I can go over how baby might feed with them prenatally, like it sounds like you guys do as well, to kind of just reassure them that yes, we're gonna be able to feed your baby, like, you know, and this is what we use here. And if you forget your bottles at home, we have more kits, so it's not a big deal. So, but I like it because it gives them, you know, 6 bottles to start out with. So. Unfortunately, Medicaid and private insurance do not cover the cost of bottles. So, you know, this is an expense that parents need to acquire. However, like I said, the nice thing about the Dr. Brown's bottles is that they're fairly cheap. And I'm honestly not sure how much the Habermans cost, but I don't feel like those are used very frequently anymore. And like
They're higher. I think they're higher than the pigeon.
are they?
So
Yeah.
the brand, I think it's the Medina
Sure.
brand.
Yeah. So pretty costly. Okay, so here in the hospital, you know, I just do a lot of troubleshooting really fast. I do a lot of troubleshooting with families, so just providing them with education on how to position the infant for feeding. It's interesting when I go into a room and talk to a parent about like how to position their baby. I have a preferred way I like to feed babies, but that's not necessarily like what's comfortable for parents. So I would say like, so I like to feed, I sit down in a chair like this and I feed the baby in front of me so I can see exactly what they're doing. A lot of moms that I've encountered recently really like to feed like this, which to me is uncomfortable. But I think they're so used to like the idea of cradle feeding that this seems like what they should do. So I see a lot of this as opposed to like in front of you. Whatever the parents want to do, if it's working for them, I'm okay with, but just making sure that they're in an upright position. And then obviously we want to look for stress cues when the baby wants to stop the feeding, ensure that we're able to identify an appropriate flow for the baby. So I feel like here in the NICU, when the baby is first born, we start fairly low on the flow rate. But then I find that they move fairly quickly up if they're born term. They move fairly quickly up in flow rate because they're kind of figuring it out. But I think with any baby that's born, they kind of are just real sleepy and shocked that they're in the world. And so it kind of takes them a little bit to kind of get feeding. And that's kind of what we're figuring out with the first couple days. And then we kind of move a little bit more quickly than we would like just a premature baby up in flow. And then obviously encouraging parents and reinforcing parents, you know, that they're able to feed their baby and they can feed breast or bottle. I know you'll be talking about breast, but if they cannot breastfeed their infant, obviously encouraging them to pump so that they can feed baby pumped breast milk. And they still feel like they're able to feed their baby that way. I think that can be really reassuring for moms as well. And then answer any feeding questions or concerns that they have while they're here in the hospital. I always give my information to parents because sometimes there can be like a week or two lapse from leaving the hospital to going to like Cleft Palate clinic. So just knowing that they have me as a resource if they run into questions or whatever. So that's kind of that. So that's like the bottle feeding portion. I think what I would say here in the NICU that I find more with like, I think providers and doctors and whatnot is that the understanding of like suction and compression both needing to be present for a baby to transfer via breast or bottle is not like fully understood, maybe, I don't know. But I often not often, but every now and then I get into a conversation with a doctor or a nurse practitioner where I'm like, they probably wouldn't be able to do that because they don't have suction. And I don't think that is fully understood. So that would probably be my biggest challenge, I guess I would say in the hospital setting, but kind of just, you know, education is key.
So with a big term kid, it's probably less likely, but with our, 34 weekers that are just trying to eat, do you see a higher incidence of Brady's and DSATs and aspiration or anything like that? Are they going to be at a higher risk? Are they x-rayed to evaluate? Are they scoped? Any indication? Does it have to be?
So that can be a little bit tricky because obviously they're going to feed with premature feeding skills, but then they also have that added layer of the cleft palate. And so that pharyngeal wetness that you tend to hear would be a huge indicator in a normal term baby for me to want to do like a swallow study, because that just means that there's milk sitting on those vocal cords, and that's why you're hearing that that wetness. However, that's to be expected with a baby with a cleft palate. So it's kind of just like trying to observe the entire picture and not just that one thing. So if baby is showing more like DSATs or Brady's, that would be definitely something that I would bring up to the medical team and talk to them about. Hey, this baby is showing a lot more Brady's and DSATs than I would expect. And these are like the stress cues that I'm finding. This is, you know, it's kind of just variable. I will say here, I don't feel like we do swallow studies very often just because they don't necessarily, sometimes they like to try and fix the problem before. Sorry, I shouldn't say it that way. Sometimes they try and try a thickened, maybe liquid, to see if that will fix the problem. And if it does, they don't feel like a swallow study is necessary. You can kind of go both ways of thinking on that. Like you can kind of try and fix the problem, or you can identify what the problem is and then try and fix it. So it's kind of one way of thinking versus the other. I have no idea if they answered your question.
Basically just follow you.
Yeah, I mean, it's just,
How do you evaluate it?
yeah. And I have come in like on the weekends. It's like undoubtedly that, you know, the babies with the cleft lip and palate are born on the weekends. And so I will come in and see babies, but.
You're the keeper of the bottles.
So the cleft lip and palate kit is down in Central Supply. So that can be ordered by anybody. And ideally I would have met with the family prior to them being born. So they would have been familiar with the bottles and whatnot too before baby's born. So.
And then you see the babies up in a normal newborn in the mom baby area. as well.
Usually, yeah. Yeah. Well, 99% of the time I do. Yeah. So the idea is to try and keep the term babies upstairs in mother baby and not have them come to the NICU just because they have a cleft.
Very excited to be here today, especially because in the decades past, a breastfeeding person wouldn't be invited to a cleft palate talk because they just can't cover breastfeeding. So I'm thrilled to be here. I have no conflict of interest to disclose. Oops. I did want to thank IABLE, the Institute for the Advancement of Breastfeeding and Lactation Education. That is a nonprofit out of Wisconsin. A friend of mine formed to educate healthcare professionals about breastfeeding. Some of the slides I've created for that entity I'm using today, so I'm going to thank them for that because they technically belong to them. I am a breastfeeding medicine specialist that works at MilkWorks in now just Lincoln. I worked in Omaha for a while. I'm heading towards semi-retirement, so I'm back to just Lincoln. But we opened in Lincoln in 2001. I was a pediatrician prior to that for a few years and then burnt out on that pretty quick. And before there were hospitalists and all that, and decided to help some friends open the breastfeeding center. Then in 2015, we opened another location here in Omaha, so moms didn't have to drive down to get help from us. Back in the day, there was no outpatient lactation support. In 2001, there was none, so you got kicked out of the hospital and good luck. Now there's more, thankfully. My objectives are to review some basic lactation anatomy and physiology, since I have this opportunity because so many people don't learn that in their training, and discuss the specific challenges of breastfeeding an infant with a cleft lip and or palate, and then touch upon the specific benefits of breastfeeding these infants. So as we've already sort of been talking about, it's important to understand how milk is removed from the breast. And traditionally, I was taught 25 years ago that there is a component of not only compression, but undulation or peristalsis from the tongue that was bringing the milk forward, and then a degree of suction. And then a few years ago, and here was, I'm sorry, I missed the main point. Another main point is breastfeeding is about attaching to the breast. So to really breastfeed well, you need to grab onto the breast past the nipple. The nipple is just for show. You must get to the breast to have the tongue adequately raise and lower to create good suction and remove the milk well, and to be comfortable for the mom, it turns out. So this is just a drawing of trying to show that the baby's drawn the tip of the nipple to at least the juncture of the hard and the soft palate to have it in far enough, and is not squishing the nipple along its length, but allowing for dilation of the ducts to bring the milk through. And then here's just pictures of examples of a nice wide open mouth. The angle of the mouth should be at least 110 degrees, very big wide open to accommodate a lot of breast tissue. And the baby on the right is a no, it's barely on the nipple. You can see milk leaking out the side of their mouth, and the mom is likely to be saying, yeah, it doesn't seem very good. All right, I am going to attempt to show video from a study done in Australia that was the first to really identify the importance of primary importance of suction with milk removal at the breast, that the tongue has to lift upwards to create a seal inside of the baby's mouth and then fall to create the suction when milk is drawn out of the nipple. Need to get on the internet, so there may be a moment of accepting cookies and getting bigger.
Ultrasound images have revealed how baby.
I'm going to turn off her voice and talk about what they are saying is we used to think that the tongue had a peristaltic movement from front to back, and that helped draw the fluid back. And then once people started actually putting an ultrasound on the breast, which again was unfortunately in Australia, not here, they figured out that, oh, you know what, that isn't happening. The tongue moves up and down. It does not peristalse from front to back. So this is just a graphic representation of what we used to think was happening, which is not actually happening. And here is back to the ultrasound image. So to orient you, here's the hard palate, the soft palate, the nipple is here. The ducts are white with milk in them. The milk is white on the ultrasound. And then it's really tricky to see, but when the tongue drops, the milk is drawn out. And there are other ultrasounds that it's a little easier to see that, but this one's pretty clearly showing the up and down movement of the tongue. Back a little bit again. I think it's really cool. Hopefully you do too. You can see the nipple stretching open. The ducts get wider open and allow the milk to move forward. And here's just again, a cartoon of that basic motion. It's so short. The tongue compresses upwards, but then recesses downwards to create the suction. All right. So these babies have trouble doing that because they can't create suction. They don't have anything to create a seal at the top of their mouth. So again, to just review if you already know this, or let you know if you don't already know this, there are two main essential components to bringing in and maintaining milk production. One is frequent nipple stimulation for prolactin hormone release. And let's talk a minute about that. Prolactin hormone, this is a graph of prolactin levels from conception through 5 or so months of nursing. The prolactin level rises gradually during pregnancy. It's the highest it's ever going to be the minute the baby is born, and then it starts to fall. And forgive my amateur graphics, but the minute the baby's born, it starts to fall. If mom does not breastfeed, nurse, or pump at all, it will fall to pre-pregnancy levels in 7 to 10 days, because the half-life of prolactin is 2 hours. I don't think it's an accident that babies are supposed to breastfeed every hour and a half to 2 to 3 max, because the prolactin falls by half every 2 hours. The baseline, if you're nursing or pumping, falls more slowly, obviously, because the baseline is a production of the surges that happen every time a baby goes to the breast or mom pumps. You get a doubling, which is not well represented in my graph, but the prolactin hormone is supposed to double every time nurse or pumps. If you wait too long to nurse or pump, you allow it to fall farther faster. And this is an area that has not been studied, and I think is a reason a lot of moms are struggling at 6 weeks of age, is they did not remove milk often enough in the first 4 to 6 weeks. But we need to look at that more closely. But you will notice that when you get to 5 or 6 months, the level does fall to near pre-pregnancy levels, and we do not understand why that doesn't matter anymore. Matters a lot what the prolactin hormone levels are in the first 2, 3, 4 months. It doesn't seem to matter so much after 6 months, and it's another area that has not been researched to understand it yet. So anywing one is nipples need to be stimulated often. Uh, how much milk a mother makes is influenced by the frequency and quality of the nipple stimulation to provide for that prolactin hormone release. Milk removal is the second essential component to continued milk production. Effective and frequent emptying of the breast is essential. There are local feedback inhibitors present in the milk that have yet to be identified completely. One is felt to be serotonin. There's research going on about that right now. But anyway, we know there are substances in the milk, and the substances sitting next to the milk making cells tell them to slow production the longer they sit there. So getting the milk out, whether the breast is full or not, is really important. And so an effective baby or a good pump is necessary for continued good milk production. I don't know why my formatting is way off, guys, but I apologize. So looking at isolated cleft lip, as we've already discussed much more in detail than I am going to now. It can take many forms, but the good news about an isolated cleft lip in regards to breastfeeding is it usually does not matter because it does not affect that intraoral suction. If you still have all of your palate, you can still create that intraoral suction. So usually all we need to do is figure out what position the mom prefers breastfeeding in and figure out how she can get a finger to lay across the defect in her upper lip to hold that seal at the lip. So the lip is a gasket. It needs to create a seal around the breast, but usually the combination of mom's anatomy and adding her finger will fill that gap. So usually not a big worry. Worked with several babies with cleft lips and no problem. Cleft palate is a separate animal. So there is no doubt that a baby that can breastfeed exclusively and successfully with the cleft palate would be a case report of in the medical journals because it is very, very rare. You cannot breastfeed without creating that suction. So they usually will struggle mightily to breastfeed well. That doesn't mean they can't breastfeed at all, however. This particular baby had a mother who really, 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 really wanted to breastfeed very badly. And she had took her baby to a dentist that was old enough to remember how to make an obturator. So this is an obturator, which is, as you notice, was not mentioned this morning because it's really not used anymore, but she was desperate to have breastfeeding work and wanted to try that. So it did not help because it just does not provide the same level of seal that an actual palate will. Anyhow, then to mention that the Academy of Breastfeeding Medicine is an organization of physicians around the world that care about breastfeeding that was formed in the mid-90s, is a probably the biggest thing that they've done for the world is create very evidence-based protocols about every topic under the sun related to breastfeeding. And they actually have one about cleft lip and palate. It doesn't say a whole lot more than what I'm saying today. But if you're interested in any of their other protocols, they are awesome and they're free to anyone in the world. So as has already been mentioned, it's important to identify when a baby has a subtle cleft. We always do a suck exam, and these submucosal clefts are can be the trickiest but really important to identify because it's amazing how a very slight defect in the musculature at the back of the palate can mess up suction. And so I have been the person to diagnose several submucosal clefts later, 1 or 2 or 3 months of age because the baby cannot suck. Create suction. You can do okay with a bottle, but not at the breast. There is limited evidence, according to the ABM protocol, and mostly expert opinion, I will say, that modifying positioning can improve the efficacy of breast emptying. It has not been my experience that you can make great differences in how well they are removing milk. But in general, we do encourage them to hold the baby upright, mostly for those reasons that are already mentioned. We don't want them to aspirate the fluid or have it come out their nose if they're lying on their side. Giving baby full breast support, depending on the shape and size of mother's breast, sometimes it can help to hold it in their mouth more to help them keep a hold of more of it, if that makes sense. And gently compressing the breast can help move more milk into the baby's mouth when they are unable to move it themselves. This is a baby who does not have a cleft, but the mother had already decided on this positioning. So I grabbed a photo because it's an unusual position. And it is similar to what we would recommend in a baby with a cleft, to hold them upright. They often do have trouble even just holding on, just latching onto the breast. They can't create enough suction to stay there. So again, the mom has to hold them out, the breast, form the breast and hold it in their mouth more. They usually do not remove milk well because they cannot create that suction. And creative positioning can help move to the breast to have that experience and decrease the leakage of milk out of their nose. Gosh, this worked at home. They should get some professional help if mother really wants to have them at the breast. A tool that might help them hold on to the breast that I've used in the past is a nipple shield. They are made of silicone. I'm sure you're all familiar with them. They come in different brands and sizes and shapes. And depending on the shape and size of mom's nipple and the particular defect of the baby, we might choose a bigger, smaller, different shaped one to help them glom on. Just a slide of the fact that if you're using a nipple shield, they really should be getting on past the nipple portion and get their tongue on the shield portion to remove milk well in a normal baby. And these babies were just happy if it helps them hold on. Just to, I don't know if you've heard of the Haka nipple shield. When it first came out, I was sort of horrified. And I have seen one mom who brought it in, so I again snapped a photo. She had a breast refusal baby. It was helping get her baby back to the breast. It is not useful for actually any milk removal, but I mention it if you had a mom who desperately wanted her baby to latch to her breast, whether it was transferring any milk or not, that this huge shape might allow for that to happen. Not probably going to transfer much milk. So this couplet is my most successful breastfeeding cleft palate baby. She had only cleft palate. Her lip was intact. Mother was a very experienced breastfeeder. I think it was maybe 3 or 4. She really wanted to do it. So they came in a few days, and I showed her how to use the supplemental nursing system at the breast. I haven't used the new version yet to know if you can squeeze on it, but this older version you could gently squeeze and push milk through. Her baby loved to breastfeed and was a fabulous latcher. We helped her stay on a little deeper by applying a nipple shield, and I put the tubing under the nipple shield so that the shield kind of helped control the flow. So mom would push milk into the nipple shield and baby was able to compress somehow, or mother's had a very abundant milk supply, was able to squirt milk out well enough that this baby exclusively fed this way and gained weight for 3 weeks. I kept telling the mom this was awesome, but we needed to watch her closely because I didn't anticipate it was going to last, and it did not. So as mom's huge supply calmed down, baby started to need bottles. But they maintained their breastfeeding relationship for several feedings a day, and it was very important to the mom and presumably the baby as well. She did start pumping to maintain her production, and we worked together on what was an appropriate amount and not excessive pumping and all of that. So you do need to push milk for these babies. You don't expect that they're going to be able to create suction and remove it on their own. And you need to be careful and respectful. That has already been identified, that we are doing the feeder-led, is that what you call it? The feeder-led version, where we're pushing milk in so the baby can access it, unless mom's having a letdown for that brief minute when she's pushing the milk out. The rest of the time, either the supplementer or this is a dad using a syringe to push the milk. You can allow them to access the milk, but you need to watch for any level of overwhelmedness and respect that and back off. So a lot of education about how to do this respectfully. And then I just included, if you ever use the feeding tube version of this supplemental method, how we advise people to clean the tubing. Since we're using a feeding tube for a reason it wasn't intended, there is no established way of cleaning the tubing. But if you look at the Lactate and the Haka and the Medela products, they all recommend to push warm, hot soapy water through to get the milk out 1, 2, 3 times. I usually say 3. Then hot water to get the soap out, and then air to get all the water out and take it over and let it dry. Getting dry is the most important thing to bacterial growth. And then I suggest replacing the tubing once a month when it's a feeding tube, but Haka and Medela don't recommend you ever replace it at all. And there have been no case reports of any problems with that, interestingly. Again, I apologize. To optimize milk production, just to beat the dead horse, frequent and effective milk removal is recommended in these babies. Starting less than 6 hours after birth, and any baby who's not nursing effectively needs to have the mom start effectively stimulating and removing milk by 6 hours. It's been shown to affect her long-term success at milk production, to get going on that at less than 6 hours. You know these babies aren't going to do it. So ideally, hand expression, if that's working for her, at least every 2 to 3 hours until secretory activation takes place, then using a quality double electric pump at least 8 times in 24 hours, and no longer than 4 hours between pumping sessions until producing more than 30 ounces in 24 hours. So just stealing from the NICU literature, 30 hours is a good amount to shoot for some backsliding with exclusive or mostly pumping. And conveying the understanding that yes, good babies sleep all night, but not everyone's breast can tolerate long periods of not removing milk. So anyone who goes more than 4 out of 5 hours between the start of one milk removal and the start of the next is risking getting their menses back, which often decreases milk production. That rise in the progesterone interferes with prolactin action, and many women struggle with milk production once their period resumes. Can put the baby to the breast as often as they would like, but need to understand that if milk production is a priority, then they must get off to a strong start and maintain it over time. Breast milk is especially valuable in this population, so it's valuable to everybody, right? So the mom is going to have a decreased risk of breast and ovarian cancer, type 2 diabetes the rest of her life, cardiovascular disease the rest of her life, hypertension, and the baby, the myriad of things, decreased infections the first year for sure, respiratory and GI, decreased type 1 and 2 diabetes the rest of their lives, decreased childhood cancers, a few IQ points, on and on. But specific to this population is those ear infections that breast milk is very, very protective against upper respiratory infections and otitis media. Nursing directly at the breast is known to help with that palatal expansion. So maybe they could avoid, there is not research on this, but in this population, but in the general population, palatal expanders are more commonly needed in bottle-fed babies than breastfed babies because the bottle is a narrow nipple and the breast is a wide thing. So it can help flatten that palate, presumably, plausibly might help in this population. And it, in other populations, has been shown to optimize infant-parent bonding. So another reason to get the baby to the breast if that is mother's wish. So in conclusion, these families deserve early and ongoing professional support from someone who can support their breastfeeding journey. I have questions, comments, experiences. Have you had any breastfeeding people?
No, we haven't, but we do educate these families, like especially during the prenatal consults, because that's the number one question, right? Is feeding, like, can I breastfeed?
Yeah.
We usually say no because the anatomy. However, we'll encourage pumping and using the bottle, and then even just the last 5 minutes just to have that bonding experience. That's been really cool. Those are the best times, you know, the end of feedings. So in terms of that, we recommend.
Yeah, I would say the same thing. I always recommend, like, especially when they're here in the first, several days, week or whatever, just to put them to breast for some non-nutritive sucking to help mom establish her milk supply. And I mean, just as an extension of skin to skin.
Yes,
So
experience, positive experience. Great. Nothing online.
Let's see here, post-surgical repair, how quickly can babies who do have some sort of breastfeeding relationship return to breastfeeding attempts? And do they anticipate them improving their abilities to breastfeed after?
Good, really good question. It's going to be up to the surgeon. I know there are surgeons who allow it immediately or within 24 hours on the East Coast, but
Yeah, typically, so if you just have the cleft lip, as you know, you can breastfeed, that's fine. We wait a good month because then we know at least the lip is well healed. Now, if it involves the cleft palate, the palate takes about a good month or so to heal, but it's still an adjustment. So you can try, but by then they're starting on purees and so forth. So timing, it just depends. I guess kind of adding to that too, like with your bottles, the valves, with the Dr. Brown specialty valves, we get questions a lot too about when can I get rid of this? And I usually say 1 month's time. And then if they don't tolerate the feeds, put that disc back in there.
yeah, I would just encourage you to listen to the moms who really, really want to do it and send them to us for support. Because we've had some success, not with removal, but with the relationship.
Do we have access to the supplementers?
we have them here, yes. We don't use them very often in the NICU. I don't know how often they use my mother baby, but that case study that you mentioned is really
It was really cool.
Yeah.
I think I saw her on day 2 or 3, very early on. I don't know that I would push an SNS in the hospital necessarily. Like I say, she was a very experienced, motivated mom, and I would be concerned about a primate just going, wow, too much. But everybody's different, is the thing. Everybody's breast is different, journey's different, productions of babies different, but it's all unique.
Do you ever get pushback from their peds when you try to do things like that?
Like what?
When like the SNS or anything, do they have any pediatricians that are?
No, I never have. Well,
Are they pretty on board?
nobody has ever contacted me directly to push back on it, and I guess I've never heard from parents any negative feedback. Would a pediatrician poo-poo the idea or say, oh honey, that's never going to work, just use this bottle? Sure, I'm sure that happens. Mostly because of their ignorance, just not knowing there's an option. Not saying they're trying to be mean or anything, but no, I've never had. I think when it regards to breastfeeding, most pediatricians are relieved to have somebody who knows something about it taking care of that because they don't know anything about it because nobody taught them.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.